And I'm going to talk about the evaluation of rheumatoid arthritis, and I'm going to focus on a slightly more practical approach because I believe there are many R1s and R2s here, even us R3s and R4s, who often have doubts. And many times, rheumatoid arthritis is the first disease we're going to diagnose or see in a consultation, and it can be really exciting for us to make that diagnosis. As you know, or those of you who have done rotations with me, or even students who have come and later became rheumatologists, you know that I'm someone who talks a lot during consultations, but the most important thing we have to do in a consultation is take a medical history, a focused medical history. Focused on what? On addressing all the doubts that patients may have regarding symptoms that could be related to the disease. Mainly, what are we going to see? Patients with pain. What kind of pain? The inflammatory type pain, which, as you all know, improves with movement, worsens with rest, wakes me up in the mornings, comes with stiffness lasting more than an hour, and can even wake me up at night. But we're also going to see mechanical type pain, nociceptive pain, mechanical pain that improves with rest, doesn't wake us up at night, and comes with less morning stiffness. However, when we talk about patients with rheumatoid arthritis, we're not going to focus only on this pain history. We're not going to focus only on the joints and stop there. No. Later, our colleagues from Vilajo and OSAD will talk about this common comorbidity, such as dry syndrome, which may be associated with patients, and we need to ask during our anamnesis about these symptoms. They might have related to associated dry syndrome or any of the other manifestations or comorbidities, whether linked to the disease itself, such as secondary osteoporosis, for example, which we will need to review, or comorbidities related to rheumatoid arthritis, or side effects that may be associated with the treatment we are administering. In addition, we would also have to assess this myalgic involvement. And as Dr. Munoz mentioned yesterday regarding patients with lupus, we need to have a more holistic view of the disease, and it is up to us to evaluate this condition along with its various comorbidities. We are also going to focus on these cardiovascular risk factors, mainly the modifiable ones, since those are the ones we can actually address during the consultation. Very well, and once we have completed the anamnesis, we've spoken with the patient, and we've guided the entire conversation, what would we do next? Well, the guidelines state that the main thing would be, for the physical examination, ideally we would have a blood pressure reading, heart rate, weight measurement, and height measurement. And it's true that our nursing team is very important in this regard. They can help us a lot, and we are always working closely with them. Many of you probably experience the same thing I do. The patient hasn't even walked in yet, and I'm already mentally scanning them from head to toe to see if they have any joint issues, if they're limping or not, if there's any deformity, any erosion. But we shouldn't just focus on this, on our physical examination. We also need to, as we were saying, we need to assess all the extra-articular manifestations that may be related to rheumatoid arthritis. A cardiac examination, a pulmonary examination, and when we're examining all the joints, we need to pay attention, palpate, and observe the intra-articular line to see if we can detect that rubbery feeling of swelling or not. To check if it's red, warm, those signs of inflammation. The same goes for the knees and all the other joints. The guidelines tell us, as Dr. San Martin mentioned, that in every follow-up consultation, we need to run blood tests including a complete blood count, kidney function, liver function, and ionogram. We need to check the lipid profile, acute phase reactants, primarily rheumatoid factor, CRP, ESR, and other acute phase reactants such as ferritin. And in addition, at the initial diagnosis, well, we should request antibody tests. If we suspect that the patient might have arthritis related to rheumatoid arthritis, then we should test for rheumatoid factor and anti-CCP antibodies. We're fortunate that just as cardiologists used to have the stethoscope and now have echocardiography, we now have ultrasound, which we'll be able to use in our consultations and which will be very helpful to us. For any doubts we might have, we can check to see whether the pain is truly related to arthritis or enthesitis. We can also observe this using Doppler imaging. Zampafi will talk about X-rays, and as Dr. San Martin also mentioned, a chest X-ray is important if we're going to start treatment. Later, Dr. Salvador will explain the exact method. We're going to start a treatment that could later cause pneumonitis, so it's also important to have an initial image of the patient, including a chest X-ray. Regarding imaging tests, when do we perform an X-ray? What kind of X-ray do we perform? Well, the guidelines state that in a recently diagnosed arthritis case, we should perform an X-ray of the hands and feet annually during the first few years. After that, it would be more up to our discretion, or it may also depend on the disease flares the patient might experience or other clinical manifestations that may appear. We have to keep in mind that radiological changes in the end serve as an example. They show us that the disease activity is not well controlled and that there is a persistence of this inflammatory activity. To give you an example, this article tells us that there is a relationship. I'll talk about the HAQ in a moment. There is a relationship in patients with long-standing rheumatoid arthritis where the HAQ can correlate very well with radiological changes. We'll talk about it later because it might help us avoid taking x-rays. For example, doing the hack or adjusting it. I'm going to talk now about what evaluation scales are, but evaluation scales, for what, Pablo? And what kind of evaluation scales? If I don't have time during the consultation, well, the frequent evaluation we do for rheumatoid arthritis can be very useful in daily clinical practice. It can be very useful in clinical trials. And for all of us residents, it will be very helpful when someone tells us we need to make a poster, at least to have some variable that can help us assess this activity, right? There are many scores that require calculators to compute, and it's true that many composite indices not only include clinical manifestations, but also analytical variables that can help us. And it's also true that the more components an index has, the more challenging it can be to use in day-to-day practice. And why do we have to use these evaluation scales? Because Euler says so, as Laura will mention later, treatment decisions must be based on the clinical activity of the disease. And not only that, but also comorbidities and the structural damage that patients may have. And for all of this, we need evaluation scales. Which indices am I going to talk about? EULA recommends these 6 indices. We have activity indices such as DAS28, CRI, SDI, and the ACR criteria, as well as quality of life or functionality scales, which include RAPID-3 and HAQ. Regarding DAS28, there's little I need to explain to you because many of you are already familiar with it. Thank you. Later on, they made an update to the DAS28 CRP. This includes the count of 28 joints, examining if they are swollen, such as checking if they are tender, a lab value such as the erythrocyte sedimentation rate, and the patient's visual analog scale, VAS assessment. The same applies to the CRP version, replacing the ESR with CRP. It's important, when we're looking at all the joints being counted here, we tend to forget and overlook some. That neither the ankles nor the small joints of the feet, for example, the toes, are included. With all this, this is a calculator, not just a basic and straightforward sum, where we input the data in order to carefully determine if we have remission with a DAS28 below 2.6. And many of you might be wondering, what's the difference between this DAS28 ESR and the CRP version? Well, that same question was asked by some senior consultants, our current bosses, and they wrote an article about it in the Journal of the Valencian Society of Rheumatology, where they observed differences between the two in detail. They thoroughly examined the differences. At first glance, Bukida, many of us can notice that CRP is much more sensitive to change. We can see that it may better reflect the current level of disease activity, whereas ESR, on the other hand, is often affected by other factors. For example, we might have other infections or anemia, which can raise the erythrocyte sedimentation rate and distort these indices. What did the colleagues from the Valencian Society observe? What the colleagues observed was that at the extremes of the scoring, that is, patients in remission or those with high disease activity, that's where the biggest differences were seen. And it was noted that patients assessed with the DAS28 CRP scored slightly lower, or vice versa. What we would say is that patients for whom the DAS28 was calculated using ESR scored slightly higher, and that gave us differences. Then the colleagues from EULAR conducted a study in which the conclusions were that both are validated in populations with rheumatoid arthritis, and both are perfectly useful in our population. Now we're going to talk about the Clinical Disease Activity Index, or CDAI. Very simple, we're going to go back to counting the 28 joints as we did with the DAS28, and we're going to add a patient's pain assessment and a physician's assessment. This one, however, is just a sum. We're no longer talking about a calculator. This is much simpler. We add up all the variables, and in the end, it gives us a little chart. We have that. If it's between 0 and 2.8, it would be patients in remission. Patients with very high activity are above 22.1. Now let's talk about the SDI, and many of you might say, Pablo, this is the same slide as the first one. And it's true, the SDI is the simplified index at first, and in the end it also includes the count of the 28 joints from the DAS28. And the same patient assessment, but we would add an extra value, which would be a lab value like CRP. In this case, remission would be considered below 3.3. Dr. Aroca from our colleagues in Murcia already mentioned it yesterday afternoon, and I wanted to bring it up because, as you are undoubtedly aware, I don't know what your opinion is, but when we're told about clinical trials, when we're told about studies, about protocols for new drugs, they always say thank you. ACR 20, 50, 70 criteria, and what happened to me was that I didn't know what they were talking about. I said, these criteria don't sound familiar to me, and the colleague explained it very well yesterday. What it tells us is whether there is an improvement of 20%, 50%, or 70%, including the count of tender or swollen joints, plus 3 of the following: the patient's global VAS, pain VAS, physician's VAS, the patient's self-assessment of disability, and the acute phase reactants. So these are indices that, when we see an ACR50 response, it means there is a 50% improvement. Many of us have this myth that counting the 28 joints can be very tedious and that we don't have enough time during the consultation. But it's true that it has been proven that this 28 joint count is valid, reliable, and accurately reflect the disease activity in patients with rheumatoid arthritis. It only takes 1 or 2 minutes for someone who has already examined many hands. It only takes about 2 minutes to perform this assessment, and as you've already noticed, for the first 4 indices, just using the DAS28 count is enough to calculate all of them. Now we move on to the 2 functional assessment scales. First, we have the Rapid 3. These are 2 questionnaires that can be given to our patients while they are in the waiting room, and they fill out a series of questions. Mainly questions about what they are doing, how their activity has been over the past week. Only the following would be included. These questions, these 3, are included as distractors, and in the end, the scoring goes from 0, meaning I have no disability, to 3, meaning I have a disability. The maximum score is obtained by adding everything up, which gives us a total score shown here as a number, plus we add a pain assessment scale and a global assessment scale. With all this, if the score is between 0 and 1, it would indicate that the patient is close to remission. We're not talking about a disease activity index, but rather about how the patients are generally doing. And for example, above 4.3, we would have high disease activity. The colleagues from Mercia also mentioned in the osteoarthritis talk the relationship with the HAQ. The HAQ also includes a series of domains, such as the domain of getting up, dressing oneself, including buttoning buttons and tying shoelaces, or washing one's hair. For instance, these everyday tasks can often be quite challenging. Each of these would be scored from 0, meaning I have no difficulty at all. I am unable to do it, and we would keep each domain. Based on the question with the highest score, there was a note that at the end of the HAQ, there are these small indexes where if the patient marks, for example, the one for getting up, and we see that they scored 1-1 on both, we would add 1 extra point and count it as 2. And these assessment scales in rheumatoid arthritis, how often should I use them? What should I do in my consultation? Should I perform the DAS28 every time I see the patient in the consultation? Well, okay. Mainly, these activity indexes should be calculated every 3 to 6 months or when there is a change in treatment, meaning for those patients. We've also seen that in the assessment scales, the HAQ correlates very well with X-rays. So, if we're doing X-rays every 2 to 3 years, once the disease has been present for a long time, we could do the HAQ 1 year and the X-rays the next, alternating between them, since the HAQ can be repeated roughly once a year and it correlates very well with structural damage. Why do we talk about these activity indices? As we've already mentioned, the treatment approach and any changes to it are going to be closely related to the disease activity. And this is very important for making treatment adjustments every 8 to 12 weeks, in line with the T2T, treat to target objective. Let me give you an example that could happen to any of us in our daily practice. We have a patient with long-standing rheumatoid arthritis who is very well controlled with a conventional synthetic drug plus a biologic. The truth is, you review their case before they come into the consultation and they say they're doing great. You look at the lab results and think, wow, they're definitely going to come in and tell me they're doing really well. But when they come into the consultation, they tell me no, that they're feeling really bad, that they have joint pain, that their back hurts. And it's true that when you go to examine them in the count of tender and swollen joints, we see that they have 8 tender joints, none is swollen. We check the ESR, an ESR of 11, and it's true that the patient tells you she's feeling unwell, scoring between 5 and 6. We hit calculate, and it tells us that the patient has, according to the chart, a moderate level of disease activity. What do? I suggest saying, no, this patient is active, I need to change the biological treatment. I thought she was doing well, but no, I'm going to change it. Or not. That is, in this type of patient, as I said at the beginning, we're going to have inflammatory type pain that will improve with our medications, and mechanical type pain, a mixed pain that won't improve. with this treatment. With this patient, we need to assess whether there is associated fibromyalgia, whether if you look at the location of the painful joints, there is osteoarthritis that could be related to this activity and the pain the patient is reporting, or if the lower back pain is also mechanical in nature and is affecting the patient's VS score, which isn't very helpful for us. All of this, why did I present this clinical case to you? Because when we talk about the goal of the treatment guidelines, we always talk about remission. But remission cannot be measured only by the indices. At first glance, this patient, according to my clinical evaluation, is in remission, but according to the DAS-28, she has moderate disease activity, so the goal proposed by the EULAR guidelines is always to start or to treat according to the trying to achieve this remission, or if not possible, which would be much easier to attain in patients with early onset rheumatoid arthritis, then in such cases, in patients with long-standing RA, what we ultimately aim for is to successfully achieve low disease activity in order to reach our primary goal. Dr. Smolin also mentions this when he talked about the goal of treat to target, in which the objective is remission. But primarily in those patients with long-standing rheumatoid arthritis who have failed multiple treatments and are still not under control, the goal will not be remission, but rather low disease activity. I ran into Dr. Smolin at the ACR and I thought, since I have to talk about this presentation, I'll take a photo with him and then show it here for you all. The conclusions of this talk would be that these ACR criteria strongly recommend the use of assessment scales, mainly when making decisions and adjusting treatment according to the treat-to-target sequence. It is important to note that these scales are used in clinical practice. The guidelines acknowledge the use of these scales, DAS-28, both the standard and the PCR version. The CDAI, the SDAI, the RAPID-3, and the HAC-D. In the DAS-28 joint count, the feet are not included. It's quick to perform, and with a trained person, any of you are already trained, you'll be able to carry out this joint count properly, which will be used by us and can be applied in multiple composite scales. And then, the treatment goal recommended by ACR and EULAR is remission, but if that's not achievable, in patients with long-standing rheumatoid arthritis, we will aim for low disease activity.